everyone. Thank you for joining Continuous Learning with BioGuard. I'll share my screen. In today's lecture, we'll share the clinical approach to bacterial respiratory infections in dogs and cats. First, let me introduce myself. I'm Yung-Tsun Lo. I got my DVN and master degree from National Taiwan University and PhD degree from Mississippi State University. Currently, I'm working as the technical support manager in BioGuard Corporation. So before we start today's webinar, I will encourage all of you following BioGuard's social media, including Facebook and LinkedIn. We share lots of knowledge and BioGuard's products on our social media. And please, if you haven't joining us, please following BioGuard. So speaking of bacterial respiratory tract infections, it actually including like a feline upper respiratory tract disease, canine infectious respiratory disease complex, bronchitis, pneumonia, pylorothorax. Due to the time limit, today we will talk the first three subjects. Feline upper respiratory tract disease, canine infectious respiratory disease complex, and bronchitis. So first, let's check the URTD, feline upper respiratory tract disease. The term upper respiratory infection is reserved for cats with clinical signs of URTD that are directly associated with one or more of the non-pathogenic viral, bacteria, or fungal organisms. So the clinical signs including the serous to mucopurulent ocular and nasal discharge, epistaxis, sneezing, and conjunctivitis. And it can, based on the whole process of the disease, if it's less than 10 days, less or equal to 10 days, that would be classified as the acute URTD. If it's more than 10 days, then it would be the chronic URTD. So first, let's check acute bacterial upper respiratory infection. The majority of the upper respiratory infection are actually associated with feline herpes virus or feline calicivirus related infections. And some of the cats with the viral infection can develop secondary bacterial infections. And the presence of the purulent or mucopurulent nasal or ocular discharge may increase the suspicion that primary or secondary bacterial infection is present, but there is no defined proof of this association because some virus or fungal agents can also induce mucopurulent discharges in cats. And several bacterial species, including Chlamydia Felis, Bordetella bronchiseptica, Streptococcus canis, Streptococcus equine, subspecies Zooepidemicus, and Mycoplasma have been isolated or detected by PCR from cats with the URTD without the presence of the pathogenic virus. So this suggests this bacteria may play a primary role in some cats showing the URI. And for the diagnosis of the acute bacterial URI, it's usually need to based on the true history. The true history should be evaluated. In particular, the vaccination status, the presence or exposure to other cats, whether cats are allowed outdoors, contact with a shelter, kennel, or veterinary hospital, health status of in contact cats, health status of in contact humans, and exposure to dog. They might be boarded or have recently come from a shelter. That may increase the and also likelihood of foreign body contact and a history of recent stress, which is thought to reactivate FHB infection in some cases. And also, ocular, oral, and otic examination need to be checked to evaluate for other primary problem. Okay? And the thoracic auscultation should be performed to evaluate for evidence of concurrent lower respiratory disease. And although feline leukemia virus and feline feline immunodeficiency virus won't cause the URI. However, if the cat are infected with FELV or FIV, it may cause the immune state, may compromise the immune issue, make them lack the ability to protect themselves. So if the cat have the URI, actually we also suggest to check the FELV antigen and FIV antibody using the rapid test to check if the cat have this issue are also important. And in diagnosis, for individual cat, there's a challenge in the diagnosis because the result from Mycoplasma culture or PCR and molecular test for FHB, FCV, chlamydia, Felis can be difficult to interpret in individual cat because these pathogens sometimes can also be detected in healthy cats. So not only diseased cats, sometimes even the healthy cat can detect, can identify those pathogens. So for the individual cat, if they don't have the URI symptom or suspicion of the infection, actually there's no need to do this test. However, if the cat have the clinical sign and no recent vaccination history, the positive result of the PCR test for FHB, FCV, chlamydia, or Mycoplasma are suggestive diagnosis test. So in BioGuard, we offer the in-clinic Q-mini real-time PCR. It can detect those pathogens cause the URI. So it's easier for you check the status of the infection in your clinic. And if it's in population level, the testing, if there's a suspected URI outbreak in like a shelter, catteries, boarding facilities, and multi-cat household, those are important. If in this situation, the molecular testing are recommended, especially important when severe clinical disease is present. And this one would suggest test multiple affected cats individually to increase the diagnosis sensitivity and positive predictive value. And the right side are some items BioGuard offer for the URI. Not only this, showing here, we also can, our kit can also detect Bordetella, Bronchoseptica pathogens. Once the cat is identified or with strongly suspicion of the URI infection, the treatment option, like in cats with the mucopurulent nasal discharge, sometimes we may think if the antimicrobial is necessary. So for this, usually would suggest the observation period is for the first 10 days, because some cats may maintain normal appetite and behavior, and usually the illness may resolve spontaneously within 10 days. So for this kind of situation, no antimicrobial treatment needed. However, if the cat shows with the mucopurulent nasal discharge, also associated with the following symptoms like fever, lethargy, anorexia, then the antimicrobial treatment should be considered. And here are some recommendations for the antimicrobial to treat the acute bacterial URI in cats. Usually, doxycycline is one of the first option because doxycycline is good first choice because it is well tolerated by cats, and most Bacteria Bronchitis isolate from cats are susceptible to doxycycline in vitro. And also, it can treat the infection of Mycoplasma and chlamydia also. So usually, doxycycline is a good option, and it's recommended to treat the cat for 7 to 10 days for the acute bacterial URI. And amoxicillin is also a acceptable option when chlamydia and mycoplasma are not highly suspected or are not involved in this infection. And some area, in that area may have higher prevalence of beta-lactamase producing organism, and over there, if the chlamydia and mycoplasma are another infection, another cause of the infection, then amoxicillin, clavulanic or augmentin can be applied to this kind of cats in this area. And after the treatment, the management of the suspected bacterial URI after the treatment would be if the antimicrobial drug is ineffective after 7 to 10 days, then bacterial infection is still suspected. then a more extensive diagnostic workup is recommended. And this will help identify the underlying cause and guide the vet target therapy. And also use sometimes we only suggest use a different spectrum only if the owner decline further diagnostic or a careful re-evaluation still support bacterial infection and no obvious underlying cause is identified. Otherwise, won't suggest use a different spectrum of the antibiotics. And if it's caused by Chlamydia felis, then longer treatment duration may be necessary to eliminate the carrier state of Chlamydia felis. And usually, most cats with symptoms with this syndrome will rapidly improve within 10 days with or without the antimicrobial administration. Then, how about if the syndrome stay longer than 10 days? That's what we call the chronic URTD. Then, when if it is lasting longer than 10 days, especially after therapeutic failure for suspected acute bacterial URI, then a more extensive diagnostic workup is recommended. And the diagnostic workup should include evaluation, including the infectious causes like cutaneous fungal disease and non-infectious causes like allergic disease, tumor, foreign bodies, or nasopharyngeal stenosis. That's the anatomy structural issue, and nasopharyngeal polyps, trauma. So all those causes should be checked to rule out those other possible cause for the URTD. An antimicrobial treatment of this cat might provide relief from severe clinical side, but it should be recognized that this cat will continue to be predisposed to the opportunities infections, often with antimicrobial resistant bacteria. And for diagnosis in chronic URTD, the bacterial culture and or AST testing are important because some multiple drug-resistant bacteria may colonize nasal passages without active infection, and the testing is primarily used to identify susceptibility of secondary bacterial infection. And this often occurs secondary to untreatable underlying conditions. And as for the treatment of chronic feline bacterial URI, the antimicrobial agent should be selected on the basis of culture and or AST test result if available. if an organism with resistance against a previously prescribed antimicrobial agent is identified and the clinical response is poor, then an alternate drug should be substituted. And if isolated, and some case, like if it's the infection of the Pseudomonas aeruginosa, then if the isolate is impure or nearly pure culture and suspected as the cause of secondary infection, then perform extensive nasal flushing under anesthesia to remove the secretions is recommended. And the treatment option may including combination therapy using the fluoroquinolone with beta-lactam antibiotics. Sometimes monotherapy like a fluoroquinolone is accepted in human otitis or osteomyelitis resistance is present. And as for the treatment duration, right now it's actually unknown for cats without underlying disease. The suggestion would be administer the antibiotics for at least 7 days. And if tolerated and clinical effective, then just continue give these antibiotics as long as there's a progressive improvement in the infection for at least 1 week beyond clinical resolution or plateau. And sometimes shorter duration may be effective in some cases, but this usually suggests for give them the antibiotic for at least 7 days. And then if it's effective for at least 1 week beyond clinical resolution. And if the URI, bacterial URI recurrence after the treatment, then see if also the mucopurulent discharge also recurred after through diagnostic evaluation. Then the previous, usually some labs may just use the previously effective antimicrobial again and give them 7 to 10 days treatment. The goal is to reach the clinical response. However, this need to be used with caution because repeated empirical treatment may cause the overuse and contribute to antimicrobial resistance and also reduce treatment efficacy. So if it's possible, don't subscribe using the previous antibiotics again in short period. Because in human studies, the organism culture within 3 months of prior treatment show higher resistance. So if no improvement after 48 hours, then suggest switch to a different drug class or a more active drug within the same class. If still effective for the treatment, then collect specimen for culture and doing the AST test is recommended. And for topical antimicrobials, it actually right now there's no evidence support the topical antiseptics or antimicrobial are effective. However, using the saline may help to make with the mild mucolytic effect and assist in clearing nasal secretions. So after the canine URTD, then let's check the canine infectious respiratory disease complex or CIRDC. This previous also known as canine infectious tracheobronchitis or kennel cough complex. And the primary symptoms include acute onset of cough with or without sneezing, and other signs including nasal discharge, ocular discharge, and fever. And fever is uncommon but possible. And the infectious pathogen can cause the CIRDC for the virus, including canine adenotype 2, virus type 2, canine distemper virus, and respiratory coronavirus, canine influenza virus, herpes virus, pneumovirus, and canine parainfluenza virus. And for bacteria, usually include Bacterial bronchiceptica, Streptococcus, and Mycoplasma. And for diagnostic approach to the bacterial cause of the CIRDC, it would include initial evaluation and through history and physical examination are essential for all dogs with suspected CIRDC, and with focus on onset and progression of symptoms. And also exposure to other, if the dog have the exposure to other dogs or high risk environment, and also with its vaccination history. And the diagnostic testing option, including the aerobic bacterial culture, AST testing, Mycoplasma culture or PCR, and molecular diagnostic of the possible pathogen like the virus and bacteria are listed here. And one thing need to be noticed is if doing the molecular diagnostic, sometimes the reduced sensitivity, it may have a reduced sensitivity if testing occurs late in the disease course due to the early peak in virus shedding. That means if we do the testing in the later stage of the disease course, then the test result may show negative because it's already past the early peak period of the virus shedding. So this need to take into the consideration when interpret the PCR result. And if there's outbreak scenarios in shelters, breeding kennels, boarding facility, or multi-dog household, then the broader testing is recommended. And that will include molecular assay, the PCR, bacterial culture, and AST test. And also, sometimes the serology testing for viral pathogens may also necessary. And to do those tests, the sample collection would suggest collect respiratory discharge specimen from multiple affected dogs for individual testing. It's just something similar to the cat URTD. In this way, can increase the diagnostic sensitivity and predictive positive value. And if it's possible, perform necropsy in case of if the dog died to help the diagnosis. And if pneumonia is suspected, then need to go through more extensive diagnostic workup. And if so when we are considering the use of antibiotic in suspected CIRDC, the etiology and general guidance of the antibiotic treatment would be like this, because majority of CIRDC cases are viral, so antibiotics are often not indicated. And because most dogs with mucopurulent nasal discharge, if they maintain normal appetite and normal attitude. This case, usually those dogs can often resolve spontaneous within 10 days without the antibiotics treatment. However, if the dog show fever, lethargy, inappetence, those are present along with mucopurulent nasal discharge, then antimicrobial treatment may be considered. So for the suspected bacterial CIRDC, if they don't have the pneumonia and show the sign we mentioned, mucopurulent discharge with fever, lethargy, and usually the first suggestion of the antibiotic sensing doxycycline, because this antibiotic doxycycline is also usually also effective against Mycoplasma and Bordetella, and they are well tolerated in dogs. And if suspected for the secondary bacterial infection with Pasteurella, Streptococcus, Staphylococcus, and other anaerobic bacteria, then there's a need for the AST test because the antibiotics option will be different. And other option, first-line option of antibiotics, if the doxycycline is not tolerated or ineffective, then can use the amoxicillin. It's also effective against Pasteurella, Streptococcus, usually, and Streptococcus. And of course, if the infection is caused by Mycoplasma, then amoxicillin won't be effective. And if have the concern of the resistant gene, then amoxicillin, chlorobenzene acid may be an option. And during the treatment, usually we still need to monitor how the dog responds to the treatment. So the monitoring is important. In addition to check the general disease course, the CIRDC is typically self-limiting or respond rapidly to antibiotic treatment. Repeat diagnostic testing is not usually necessary unless pneumonia is suspected. And bacterial culture, after successful treatment, bacterial culture is not recommended. And for CIRDC, it's not linked to chronic upper respiratory disease in dogs. And the treatment response and follow-up for usually most dogs show quick clinical improvement for the bacterial CIRDC. However, if no improvement after 7 days of initial antibiotic therapy, the bacterial infection is still suspected. Do not immediately switch to broader spectrum drug. Instead, need to perform a more extensive diagnostic workup first to identify if there's other underlying cause. And for antibiotic option, avoid premature escalation to fluoroquinolone, azithromycin. Only use this antibiotic after further diagnostic supports their necessity to prevent the resistant bacteria produced. And then let's check the bacterial bronchitis in dogs and cats. For the bacterial bronchitis, the cause of this bronchitis including inhaled irritant, and for infectious agents including the bacteria, virus, and even the Dilophilaria immitis, the heartworm, and respiratory parasites like Toxocara canis, tissue migration, and also cause the bronchitis. And pharyngeal or esophageal dysfunction and allergic reactions will also cause the bronchitis. So checking this underlying issue are also important for the bronchitis diagnosis. And then in bronchitis, if it's acute bronchitis, it may occur secondary to primary infectious diseases. It's similar, the cause in cat is similar to the acute and chronic URI in cats and CIRDC in dogs, so we won't repeat here. And the clinical signs, diagnostic approach and treatment generally follow those outlined in the we just mentioned above. So we'll just talk a little bit here. And for chronic bronchitis and bronchopneumonia, it can develop in animals infected with Bordetella bronchiceptica and Mycoplasma. It may also arise in animals with other inflammatory bronchial diseases, or is caused by anatomic defect, like laryngeal paralysis or collapsing trachea. Those can also cause the issue. So careful and through diagnosis are important. And for secondary bacterial bronchitis, they are often linked to natural oral microbiota, and common bacterial agent is similar to those we just talked, the secondary bacteria URI in cats and secondary bacteria CIRDC in dogs. And one thing need to pay attention is many dogs with chronic bronchitis, they do not have significant bacterial growth on broncholateral lavage, indicate that not all cases are associated with bacterial infection. And when we suspect the bacterial bronchitis, the diagnosis indicate we including the radiographic evidence of bronchial disease and clinical sign may suggest a bronchial inflammation. And the recommended diagnostic procedure would use like a airway washing for cytological examination. This one can determine what type of inflammation it is. And also, those washing can send to the lab for Mycoplasma culture, Bacterial culture, and also can do the antimicrobial susceptibility testing. And the specimen collection method will include in the bronchoscopy. This is the most accurate method. Trachea washing is acceptable if the disease is diffuse or the bronchoscopy is unavailable, unaffordable, or have some high risk. However, need to be noted, one thing need to be noticed is the bronchial lavage and brush specimen result may not always align, means the result may be different. And for interpretation of the finding of the result, it would be suggestive for bacterial bronchitis, like if you have a neutrophilic inflammation, that when you are checking the cytology, seeing lots of neutrophil, then that's an indicate. And the intracellular bacteria observed are also an indicative. And positive bacterial culture and characteristic radiographic finding, those are all suggestive of the bacterial bronchitis. And this need to with the caution, because the trachea is not sterile in healthy dogs. So low bacterial count without intracellular bacteria may not indicate infection. So this need to be paid attention. As for the treatment of the suspected bacterial bronchitis, then it's usually the bacterial culture and or the AST test results are important for the treatment. And if your clinic don't have the in-clinic AST testing, then you may need to send to the reference lab. And while in waiting, the mild case, the no antimicrobial treatment recommended. However, in severe case, without the AST result, or you are waiting for the AST, the first option, same thing, is the doxycycline for 7 to 10 days, because it's effective in vitro against Bordetella bronchiceptica and also for the respiratory Mycoplasma infections, and it has a low rate of adverse effect. And then if your hospital have the in-clinical antimicrobial susceptibility test in-clinic machine, and you can get the result immediately, at least 1 day, within 1 day after collecting the sample, then you can just, based on the AST test result, to select the best antibiotics for the treatment. And if not, after you get the result, you can adjusting the treatment based on the result you get. Then if the result show the antibiotic you provide is effective, then just keep using the same antibiotics. If the result, the antibiotic you choose is not effective to the bacteria, then need to initiate another antibiotic treatment. And if the results show intermediate, that means you may need to increase the dosage of the antibiotics if there's no other option. So based on the antimicrobial susceptibility testing are important for the treatment of bacterial bronchitis. And also need to, based on the drug's ability to penetrate the blood-bronchus barrier. And BioGuard, right now, we are launching the in-clinic mini AST machine, which is specifically designed for in-clinic antimicrobial sensitivity test. It can provide the results within 24 hours that you quickly get the accurate result and choose the beta, provide you the option to choose which antibiotics are good and effective for the treatment. So if you are interested in this product, you can contact BioGuard. And for the treatment, if it shows positive response, so like if clinical sign improvement within 7 to 10 days, then can continue the treatment until 1 week after the symptoms resolution. The optimal duration is actually unknown. Recommended is just based on the clinical experience, but continue treatment until 1 week after symptom resolution is usually a good option. If the treatment, there's no response to the dog is no response to the treatment, then it may have primary chronic bronchitis. That means it's caused by non-infectious issue. That means may need some other extensive diagnostic workup. And if it's the Mycoplasma infection cause the issue, and because the Mycoplasma is difficult to culture, so usually regular reference lab won't do the Mycoplasma bacterial culture, and of course no susceptibility result because the culture of the Mycoplasma is kind of time consuming. It takes time. Definitely may take 4, 5, or even 7 days. So if it's the Mycoplasma infection, the treatment is typically empirical. And commonly used drug, of course, is doxycycline. Others are minocycline and fluoroquinolone and azithromycin. But the last two usually don't take the last two for the first treatment because just keep them until they are really necessary using the fluoroquinolone and azithromycin for the treatment. And so for the monitoring of the treatment, if the bronchitis is associated with Mycoplasma or bacteria, the single course of antibiotics may resolve the bronchitis caused by them. And sometimes the prolonged treatment may be necessary in some cases. So the safest way is give the antibiotics at least 7 to 10 days. And if in doubt, just keep provide until 1 week after the clinical sign resolve. If there's recurrent or secondary infections occurs, this may occur if underlying inflammatory conditions are present, like allergic issues or anatomic defects. So this may make the secondary infection or the recurrent of this bacterial bronchitis. And managing the primary disease can help reduce recurrence of the secondary bacterial bronchitis. And monitoring tools, including the thoracic radiograph, this can check the bronchial change. However, it has limited sensitivity. And repeated cytology and culture may be indicate in persistent or recurrent cases. And then for the conclusion, it's actually quite a clinical challenge for the respiratory tract disease in dogs and cats because it's frequently linked to primary or secondary bacterial infection and remain a leading cause of antimicrobial use, often resulting in misuse, overuse, or inappropriate prescribing. And unlike human medicine, the veterinary care still lacks comprehensive evidence-based treatment guideline for these conditions. So to improve clinical decision-making, there's a pressing need for prospective studies that evaluate various treatment options and durations. And additionally, research should focus on establishing standardized methods for collecting clinical specimens and interpreting bacterial culture results to ensure consistency and accuracy in diagnosis and therapy. And thank you for your listening. That's the question. The allergic symptoms don't include food-related allergy. Is that right? It depends. Usually, the food allergy, the food allergy won't affect. Usually, the food allergy won't affect the respiratory. However, some may have severe situation cause the systematic issue in the whole body. If that's in case, sometimes it may also cause the respiratory sign. This need to pay attention. By the way, if you need a PDF, please leave your name and email on the Q&A session. We'll send you the PDF after the webinar. And And one question is tyrosine an ideal agent to treat this respiratory infection? Because right now, tyrosine is more commonly used in the production animals. It can be effective to some gram-positive bacteria like Staphylococcus, Streptococcus. And I'm not because it in chicken it can treat the Mycoplasma infection. In dogs, it's rarely used for the respiratory infection. Yeah, if you need a PDF, please leave your name and email on this Q&A session. Yeah, aside from antimicrobials, what other supportive treatment should we consider? And of course, because this one, in this session, we only focus on the antimicrobial usage. So yeah, other supportive treatment is also recommended for the respiratory infection, just to decrease to relieve the symptom. So other supportive therapy are also recommended for the treatment of the respiratory infection. So any alternative of antibiotics can be available to use in URI of cats. Actually, there are quite a lot can recommended, like for amoxicillin, ampicillin, and cefazolin, cefalexin, and also gentamicin, meropenem. They are also they also can be applied to the respiratory infection, bacterial respiratory infection treatment. Uh, just the most common use is the doxycycline, amoxicillin, and for others, would suggest if you have the AST result, then just follow the AST result. And thank you for participant in today's webinar, and we'll see you again next month. Thank you.